shift topics next to talk about new VTE bundles in OB. How will this affect OB anesthesia? And I know you've heard a lot of very important topics over the course of the last few days or so, and this for me is one of the biggest ones that may impact upon our practice as OB anesthesia providers. Okay, so what we're going to aim to do over the next 20 to 30 minutes or so is initially look at some of the epidemiology of venous thromboembolism, or VTE, associated with pregnancy, and then that will provide us with some background when we start to dig deeper and look at the information and recommendations that are coming out from, in general, obstetrical groups about the prevention and management of VTE in the form of VTE bundles. We'll then look at some guidelines that are coming out from anesthetic societies about how we should manage patients who are anticoagulated when we're considering them for neuraxial anesthesia. And then we'll tie this all together, hopefully at the end, to figure out how this is relevant and how we're going to deal with this on our labor and delivery units. Okay, so to start with, how common is VTE associated with pregnancy in the US? So here we have some data from Guardian colleagues that looked at a very large nationwide inpatient sample. It's a hospitalization-based data set. And what we can see here is that the rates of VTE in women who are hospitalized before delivery, during delivery, and after delivery are pretty low. So it's about 0.5 per 1,000 deliveries within each time epoch, or 5 per 10,000 deliveries if you're trying to figure out what half a pregnancy means. So it's pretty uncommon, which is great. You may be wondering, well, is the rates during delivery higher than it is after delivery? It's probably not the case. It's probably the case that some of those delivery patients had a VTE in the very early period after delivery. So that probably belongs to the postpartum group. Now, the other thing to bear in mind is that the incidence of VTE postpartum varies depending upon when it occurs after delivery. So here's some really interesting data from Jonathan Morris's group in Australia, which shows that the incidence is highest in the very early period after delivery when you're looking at postpartum VTE. So the rates are highest in that first week or two compared to, say, 4, 5, 6 weeks out after delivery. The other thing you can see on this graph is that patients who undergo C-section have a much higher incidence of early VTE compared to patients that have a vaginal delivery. So it's not surprising that much of the focus about postpartum thromboprophylaxis is focusing on women that have C-section rather than vaginal delivery. So why is this important? Well, it's important because despite our best endeavors, despite advances in medical, surgical, and anesthetic practice, unfortunately, we're still seeing women dying from VTE, or pulmonary embolism, associated with pregnancy. This is data from the CDC that came out in 2016, looking at maternal deaths that occurred between 2011 and 2012. And as you can see on this chart, about 9% of all maternal deaths were due to pulmonary embolism. So it's not surprising that this is a topic of much interest to all of us, including our obstetrical colleagues. And therefore, they have published over the years a series of guidelines to help provide providers with information about how to better prevent and treat patients against having VTE and morbidity associated with VTE. And what you can see here on the slide are front pages from various sets of guidelines from national societies. So if we go from sort of anti-clockwise, the chest guidelines come out from the American College of Chest Physicians. The practice bulletin is the header from the American College of OBGYN. At the bottom on the left is the top of the first page from the Royal College of Obstetricians and Gynecologists from the UK. Go to the top right column, SOGC, that's the Society of Obstetricians and Gynecologists in Canada. The middle on the right is the first page from guidelines from the group in Australia and New Zealand. So it's great. Obviously, there's international appreciation of the importance of trying to prevent and treat venous thromboembolism. And this has been nicely pulled together. All the guidelines have been nicely pulled together by Shannon Bates in the reference that you can see in the bottom right-hand area of the slide. Now, who should we anticoagulate? The recommendations for anticoagulation invariably involve patients who have risk factors for VTE. Not surprisingly, if someone has a VTE during pregnancy or in the period after delivery, these patients will get therapeutic anticoagulation. Far less commonly are people who have mechanical heart valves. So not surprisingly, these women receive therapeutic anticoagulation to try and prevent problems with systemic embolism. And then lastly, women who have antiphospholipid syndrome, who have a history of recurrent miscarriages, are also candidates for prophylactic doses of anticoagulation. Okay, so that's great. We've got some guidelines from obstetrical societies. We have an idea about which women should be anticoagulated, but there are problems. And the problems are that the recommendations that come out from some of these societies are not often consistent. And this has been flagged by a group in Colombia, because they were concerned that the recommendations differed for patients who would be candidates for thromboprophylaxis after C-section. So they took a typical cohort of patients who had a C-section at Columbia, and based upon the characteristics of that cohort, they determined what proportion of those women would be candidates for postpartum thromboprophylaxis, depending upon the set of guidelines that were published from 3 different groups. So if you look at the guidelines from the American College of Chest Physicians, they calculated that about 35% of patients would receive postpartum thromboprophylaxis, whereas if you look at the guidelines from the RCOG in the UK, they're much more conservative, so the vast majority of their C-section patients would have got thromboprophylaxis, whereas the American College of OB/GYN guidelines that came out in 2011 are much more lax, and it's therefore a very small minority of patients, depending upon their criteria for thromboprophylaxis, would have received prophylactic anticoagulation after C-section. So there's a very wide range of criteria that these societies are using. So it's not surprising that this is causing some consternation amongst our obstetrical colleagues. And they felt that there was a need to bring in a group of people to establish better consensus for determining who should get anticoagulation during and after pregnancy. So as a result, a bundle has been released by an expert group formed by the Council on Patient Safety. So this group has been formed by a separate group under this umbrella called the National Partnership for Maternal Safety, and we'll be focusing on the guidelines from this group in the next few slides. But there are other groups who are also interested in establishing recommendations in the form of a bundle as well. And for those of us that work in California, you may be familiar with bundles that have been released by the California Maternal Quality Care Collaborative. And they are in the process of formulating information in the form of a bundle relevant to the prevention and management of VTE. And it's very likely that some of the information in their bundle may be different from what we're seeing so far in the information from the National Partnership for Maternal Safety. So far, the National Partnership for Maternal Safety have published their guidelines in different obstetrical and anesthetic journals. And in fact, the bundle came out in ANA last year. So the people in this bundle were, many of them were obstetricians. We did have representation from the OB anesthesia community in the form of Richard Smiley, which was great. So let's look at what is contained within the bundle. So the bundle contains 4 separate domains: readiness, recognition, response, and a reporting/systems learning approach. What is readiness? Readiness is all about developing a risk assessment system. So you're looking at patients, seeing what their characteristics are to determine whether they are at risk for VTE. Recognition is, well, if you're recognizing that they are at risk, then making sure you have a system in place to determine who should get adequately dealt with in terms of prevention or treatment. Response is, how are you going to action that? Are you going to consider them for mechanical thromboprophylaxis or thromboprophylaxis, or even therapeutic anticoagulation? And then lastly, a reporting or systems learning-based approach where you've got an audit cycle in place where you're assessing what the outcomes are for women who are at risk for VTE, who receive some form of prophylaxis or treatment, or if women were not at risk and they got a VTE, what was it that we could do better to try and improve the likelihood of us reducing those problems for similar women in the future? So all of this makes a lot of sense, which is great. So who are they recommending that we should anticoagulate? So their recommendations pretty much align predominantly with the guidelines that have come out with other obstetric societies. So if you have a thrombophilia that's associated with a moderate or high risk of VTE, it's very likely that that patient will receive some form of anticoagulation. If you've had a prior VTE that's associated with a provoking event, it's also very likely that you'll receive anticoagulation as well. So all of this, as we've mentioned already, is very much aligned with what we've seen before from other obstetrical societies' guidelines. But there is a separate problem here because they've extended some of the guidelines that have come out from previous obstetrical societies to allow for or to account for other potential high-risk women. So our antepartum floor is often has women who with high-risk medical and/or obstetrical conditions. And many of these women may be admitted for several days, a week, or several weeks. So the M.B.B.S have said that if a patient is admitted for more than 72 hours, then we should consider them for thromboprophylaxis because there may be concerns with prolonged bed rest. So they should receive low molecular weight heparin or BID twice a day unfractionated heparin. And if they are at high risk for childbirth, which I find somewhat amusing because if you're pregnant, then you probably are at risk for delivery. But I guess what they're trying to say is that if they are likely to deliver imminently or in a short period of time, if they're on low molecular weight heparin, then convert them over to unfractionated heparin because the half-life is shorter. And don't worry, we'll touch upon some of the pharmacokinetics of these drugs next. Now this is a big deal because we may not have seen these women getting thromboprophylaxis until now. So if this is what's coming out from these obstetrical groups, we're going to be seeing more women on our antepartum floor that are receiving anticoagulation. And if there's concern for OB that we should be delivering these patients urgently or emergently, and they're receiving anticoagulation, then for us it's a big deal because that may significantly modify our anesthesia plan, and we may be considering GA for these patients as opposed to neuraxial anesthesia. After vaginal delivery, they're also commenting that if patients have a history of VTE or thrombophilia, that we should now be considering thromboprophylaxis for these patients. So that may influence the timing of when we are going to consider starting thromboprophylaxis if you've placed a neuraxial block. And they also state that if someone's had a C-section, if they're at high risk for VTE, they don't go into specifics about what they mean about high risk, but if they are determined to be at high risk, then they should be candidates for thromboprophylaxis. So these are obviously, all of these situations are a big change or a big shift in terms of our scope of work, because we may have to account for a lot more women who are anticoagulated before delivery or who are candidates for anticoagulation after delivery in terms of our neuraxial anesthesia practice. Now, obviously, they were concerned, and the biggest reason why we're concerned is when we're dealing with a patient who may be receiving anticoagulation, who is requesting or maybe a candidate for a neuraxial block. Our biggest worry is putting a block in or taking a catheter out, and this patient incurring a spinal or an epidural hematoma, which we know is associated with major neurological sequelae. It's a major neurological catastrophe. So what do we know about the incidence of spinal and epidural hematoma within the obstetrical population? There's a number of reports that came out fairly recently, and they looked at M.B.B.S, which is the large database comprising multiple perioperative centers, where they're pulling information from these centers from the EMR data to look at outcomes. And what they found was that in over 62,000 women that had neuraxial blocks, there wasn't one single reported case of an epidural or spinal hematoma. In Bomdiangelo's SCORE project, which you heard about a little earlier, they looked at 250,000 events where there was a block that was placed, and only one patient incurred a spinal and epidural hematoma. We don't know whether this patient received anticoagulation. But the take-home here is that the incidence is very, very rare, at least from what we've seen previously. When we look at closed claims data, this is information that's at the moment unpublished that has been provided to us very kindly by Lisa Leffert and colleagues. They looked at data from the closed claims survey between 1990 and 2016. There were over 500 claims. Not one of them involved complications associated with a spinal and epidural hematoma that went to a suit. So far, this is very favorable. But remember, this has been involving populations where they weren't necessarily anticoagulated to the same degree that we may be seeing in the future. The other problem we have is, as well as the shift in terms of patients who are receiving anticoagulation from obstetrics, there is going to be a change in the recommendations from the American Society of Regional Anesthesia, or ASRA, in terms of the minimum time windows that we may need to consider between the last dose of anticoagulation or anticoagulant and putting a block in, and in terms of the time windows from placing a block or pulling an epidural catheter to restarting anticoagulation. So we're stuck in the middle. This is the situation we are in right now. We have the new sets of guidelines from the obstetrical societies. We have our friends over in ASRA that are likely to change their recommendations for who should or should not get a block, depending upon when they last got an anticoagulant dose. And we, in fact, you could argue we can shift that to the patient, are stuck in the middle trying to understand who and when and why we should consider performing a block. So let's look at what we know from the guidelines that have come out from major anesthetic societies for the neuraxial block placement in patients who are anticoagulated. So the last official guidelines from ASRA came out in 2010. Last year, they unofficially released their latest guidelines, not in print, but it was only released on an app that was available on an Android phone or an iPhone. Now, I'm not marketing for Apple, I'm not marketing for any smartphone device using Androids, and I'm certainly not a representative of ASRA, but the only way you can get this information is unfortunately by downloading the app on your smartphone. So don't worry, we'll be covering some of the information on the next few slides in terms of what ASRA have unofficially announced in terms of their revised guidelines. We still haven't seen official release of these guidelines yet in print, but we are hoping that they are going to be coming out in the next 3 to 6 months or so. We'll compare the guidelines from those that have most recently been published by the European Society of Anesthesiology, that's the ESA. Those came out in 2010. And we'll also look as well at the anesthetic recommendations that came out from the National Partnership for Maternal Safety. Sorry, there's a change in the wording there. The National Partnership for Maternal Safety that came out in the bundle last year. Okay, so not surprisingly, the most commonly used anticoagulants that we see in our practice are heparin and low molecular weight heparin. The guidelines that have come out from national anesthetic societies invariably rely upon expert consensus. And the reason why is that there is very limited data that's come out from studies looking at the PK and certainly the PD of these drugs. And there's hardly any information available in terms of the PK and the PD of these drugs in the pregnancy literature. Whoop. Okay, so let's look at heparin first. So let's just remind ourselves about what heparin is. It's a glycosaminoglycan. It's got variable molecular weight, and its primary mode of action is by binding to antithrombin 3, which inactivates a number of different clotting enzymes. What are these enzymes? Well, they invariably reside on the intrinsic side of the old clotting cascade, so 12A, 11A, 9A, 10A which lives in the final common pathway, and factor 2A. So if you inhibit all these clotting enzymes, that results obviously in decreases in fibrin formation, and also there's a decrease in the number of important clotting factors that are involved in the amplification process, so 5A and 8A. Its primarily or predominant mode of action is on 10A and on 2A. So if there is a slide to take home from this talk, it's probably this slide here. And we'll walk through this slide very slowly because I know it looks quite busy, but this is probably the most important slide that you should probably take home with you after this talk. So back in 2010, what ASRA said was that if you have a patient that's receiving unfractionated heparin and their dose was less than 10,000 units a day and they received no more than 2 doses a day, that it didn't matter when you placed a block in terms of timing. There's no contraindication. You can place a block after 20 minutes, 30 minutes, an hour, 2 hours. There's no minimum recommended time period that you should wait for between the last dose and doing a block. If you look at the information on the app that came out last year, they've made a dramatic shift in their recommendation to say that you should wait 4 hours, but preferably 6 hours from the time of the last dose before you consider the patient for a neuraxial block. That's a big change, and that's obviously going to impact on us if we're trying to figure out when we should place a block on patients that are receiving unfractionated heparin. Why? Well, it's not entirely clear, but the feeling when we speak to our ASRA colleagues is that they wanted to be consistent with the recommendations that came out from the European Society of Anesthesiology, where you can see they also recommended 4 to 6 hours back in 2010 for patients that are receiving up to 15,000 units of heparin a day. Now, there's some acknowledgement of this problem in the guidelines that come out from the National Partnership for Maternal Safety, who have stuck to their guns and said that there should be no minimum time interval for patients that are receiving less than 10,000 units of heparin a day. And we'll see why in a minute when we look at some of the PK data for unfractionated heparin in pregnancy. What about if you placed a block or you're taking an epidural catheter out? How long should you wait before you restart prophylactic doses of unfractionated heparin? So ASRA back in 2010 said wait at least an hour. If you look at their most recent information on the app, they're saying, not so much of a worry, you can start immediately. So that's a subtle change. The Europeans say wait an hour, and the National Partnership for Maternal Safety say there's no restriction. So you can see that there's some variation even in terms of restarting heparin, but the biggest concern is when you're placing a block for patients that receive their last dose before delivery. So this is obviously going to cause us a lot of problems. I'm sure we'll be feeling like that, and Bob's right, my hair's falling out, and here's one of the reasons why. Okay, so what do we know about the PK of unfractionated heparin in pregnancy? Well, this is a very interesting study that came out where they took a bunch of healthy volunteers who were pregnant. They gave them a single dose of unfractionated heparin, 143 units per kilo. So about 70 kilos, that's about 10,000 units. And then they measured their plasma heparin concentrations over time. So that's what you're seeing on the x-axis for both of these graphs. And also they measured their APTT levels over time as well, and that's the graph that you can see on the right. They compared them to healthy non-pregnant women. So the black circles on both graphs are the non-pregnant women, and the white circles on both graphs are the pregnant group. So what you can see here on both graphs is that when you compare the heparin concentration changes over time, they're much lower in the pregnant population than they are in the non-pregnant group. And similarly with the APTT levels, they're much lower and they reduce down to a normal level or baseline level much sooner compared to the non-pregnant group. Now remember what ASRA said. ASRA said in their most recent guidelines that we should wait 4 but preferably 6 hours from the time of the last prophylactic dose of heparin. So let's use that and we'll extrapolate what the heparin concentrations are for the non-pregnant group. So the black arrows here vertically going up show you what that time period is in minutes if you're trying to calculate what 6 hours is. And then the horizontal bars shows you the heparin concentration at 6 hours for the non-pregnant group and the APT levels for the non-pregnant group at 6 hours as well. Now what you can see here is that the heparin concentrations in the pregnant group and the APTT levels invariably do not go above those horizontal bars at any time point. So this should provide us with some reassurance that perhaps what ASRA is saying in terms of the new guidelines don't necessarily apply to pregnant women. And we should perhaps not need to wait at least 6 hours before performing a block for these patients because their APTT levels and their heparin concentrations don't go above the concentrations at 6 hours for women who are non-pregnant. Okay, so what about IV heparin? Well, there isn't an awful lot of change in what we've seen recently compared to what's come out before. ASRA don't make any recommendations between the time of turning off the heparin infusion and performing a block in any of their guidelines from 2010 and 2016. But they do say that if you have an epidural catheter in and you're running an infusion, I guess this applies maybe to more non-obstetric patients, maybe after cardiac surgery, turn the infusion off, wait 2 to 4 hours at least, and then you can take the catheter out. Europeans are a little more conservative. They recommend 4 to 6 hours at least before you pour the catheter or perform a block. And in the National Partnership guidelines, they don't make any recommendations specifically about about heparin infusions, but they do say for patients who are receiving therapeutic heparin, you should wait 6 hours. In terms of the time period between doing a block and removing a catheter and restarting heparin infusion, then in general, most of the guidelines say you can wait at least an hour before you restart the heparin infusion. Okay, so let's move on to look at low molecular weight heparins. So we'll remind ourselves very briefly about what these drugs are. They're much smaller drugs in terms of their molecular weight than unfractionated heparins. They're formed by chemical and enzymatic depolymerization. As we saw with heparin, they do bind to antithrombin 3, but they have other actions as well, which includes inhibition of factor 7A and tissue factor binding, and they increase the release of tissue factor pathway inhibitor. Because these molecules are much smaller, they have less of an effect on factor 2A, which is why there's a reduction in the 2A-10A ratio. But the nice thing is their PK is more predictable, and many people like them because they have fewer side effects compared to unfractionated heparin. So less osteoporosis and potentially less or a lower incidence of allergic reactions. So let's move on to see what the guidelines are for patients that are receiving low molecular weight heparin drugs. Now, there's some good news here. There isn't a lot of change in terms of what ASRA is saying in their most recent guidelines compared to what they said back in 2010. So wait at least 10 to 12 hours in patients that are on a prophylactic dose before you consider performing a block. And the Europeans say much the same, 12 hours, and the National Partnership says 12 hours as well. So that's good. There's more consistency here for low molecular weight heparins. But there is a difference in terms of what ASRA are saying now compared to what they said back in 2016 for the time period between when you place the block before you give the next or postpartum, post-op dose of low molecular weight heparin. Back in 2010, what they said was for the first dose, wait at least 6 to 8 hours if you performed a block before you give the first dose of prophylactic low molecular heparin. If you're wondering about when to take the catheter out, wait at least 2 hours after you take the catheter out before you give the first post-op dose. In 2016, they've changed their recommendation, and they're actually saying you should wait longer. So if you've performed a block, what they're recommending now is that you restart the low molecular weight heparin on the day after surgery, or at least 12 hours after surgery. If you're wondering when you can start to give the prophylactic heparin again, low molecular weight heparin again after an epidural catheter once that comes out, they're saying wait at least 4 hours, assuming that at least 24 hours has elapsed since the time of surgery. So that's much longer than what we previously saw back in 2010. And I guess our concern is if you tell that to obstetricians, they may not like it if you say to them, well, you can't start postpartum anticoagulation until the next day. They may say, well, I want to give it tonight, or I want to give it this afternoon if you've done a C-section in the morning. And we'll come up with some ideas about a workaround for that in a little bit. The Europeans recommend a slightly lower time period of 4 hours, and the National Partnership for Maternal Safety also recommend 4 hours. You can see that there's some disconnect here in terms of the consensus for the minimum time periods for restarting prophylactic low molecular weight heparin after a block is performed. So again, HOMA is not happy. What about for therapeutic low molecular weight heparin? Well, again, there's good time consistency here. They generally say wait 24 hours between the time of the last dose of therapeutic heparin, a low molecular weight heparin, and performing a block. What about for restarting afterwards? Well, back in 2010, ASRA said wait 24 hours after the block is performed and at least 2 hours after an epidural catheter comes out. On the app, they're saying a lot less. So they didn't say much about when you should restart after a block is performed, but they did say you can initiate the low molecular weight heparin after catheter removal, but no time interval was stated. So I hope when the formal guidelines come out, they perhaps solidify some of those recommendations. The Europeans say wait 4 hours, and the National Partnership for Maternal Safety are quite conservative, and they say wait 24 hours. So that's consistent with what ASRA said back in 2010. And there's more. So not only are we seeing a change in the recommendations for some of these time periods depending upon the drug, but on top of that, to add insult to injury, what ASRA is saying now in the app is that we should restrict the use of nonsteroidal anti-inflammatory drugs if patients are receiving any of these anticoagulants after a neuraxial block. Now remember what Mark just told you. Non-steroidal anti-inflammatories are really important in optimizing post-cesarean analgesia. They're essentially like the crux or a central component in terms of how we provide analgesia after cesarean section. And yet this is what ASRA is saying, and there's no clear supporting data for it, despite the fact that we know, as Mark showed us, that non-steroids are important for optimizing analgesia. So what does that mean in terms of us? As OB anesthesia providers, what do we do in terms of best practice? Well, from a system standpoint, there's probably some sort of common sense approaches that we need to think about. So a protocol needs to be established at your institution. That makes a lot of sense. When we're hearing about these patients from our OB colleagues, it's really important that we hear about them early, so we consult with them early about what the likelihoods or the options are in terms of analgesia and anesthesia during the period of labor and delivery. As we all know, Mother Nature has a habit of wrecking plans in terms of how we deal with obstetrical patients. So it's important that we closely communicate with obstetricians and maintain that communication if plans for delivery change during the course of the antepartum period. So a multidisciplinary plan is essential, and that involves talking to OB, and it may involve talking to hematologists as well. Once you've formulated that plan, you then present the options to the patient, and the decision needs to be patient-centric. So you need to get buy-in from the patient as well. So you may want to talk about the situations, the scenarios where you may consider a GA, and you may consider a neuraxial block. You state what you think those recommendations should be, you state your opinion, and then you see if the patient provides you with buy-in for each of those. So let's get into the brass tacks. What can we say based upon what we've seen so far from guidelines from OB and also from ASRA? So what we would say is if the patient received the last dose of prophylactic low molecular weight heparin less than 12 hours ago and they want a block, or it's been less than 24 hours since the last dose of therapeutic low molecular weight heparin, and they're in labor and they're wanting analgesia, then we probably consider using a PCA until 12 hours and 24 hours has elapsed. If they require cesarean section, then it invariably means that a general anesthetic is required. Now that's important because when we're dealing with patients who are antepartum, it's really critical that you talk to OB, because if these higher risk patients are sitting on the antepartum floor, so for example, a morbidly obese patient who's developing worsening hypertension from preeclampsia, you want to talk to the OB and remind them that if they're concerned about imminent delivery, to stop the low molecular heparin or try and bridge to unfractionated heparin to give yourself a better opportunity to consider the patient for a neuraxial block. For postpartum thromboprophylaxis, because of the change in the ASRA guidelines, you may consider shifting to using sub-Q unfractionated heparin for the first 24 hours, which might make your obstetrical colleagues happier, and then they can give the first dose of low molecular weight heparin on post-op day 1. And that's one approach that's been put forward by the National Partnership for Maternal Safety. Obviously, bear in mind that low molecular weight heparin is eliminated renally, so if you're dealing with a patient that's got renal impairment from pre-existing renal disease or from a hypertensive disorder with pregnancy, that you need to reduce your dose of low molecular weight heparin appropriately. Now, the other thing that the National Partnership are saying is that there should be no contraindication to performing a block in terms of a minimum time period between the last dose of unfractionated heparin if it's less than 10,000 units a day and the time period when you want to use a spinal, combined spinal, or epidural. Now, this is very, 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 very likely to be endorsed by a consensus group, which I'm lucky to be part of, that's been put together by SOAP, who are going to be coming out with their own consensus statement, which is specific to the obstetrical population, which will provide direct information to help OB anesthesia providers who are trying to deal with the guidelines from OB and the forthcoming guidelines from ASRA. So these will be very OB-centric, very OB-focused guidelines, and we hope that these will be coming out in the next 12 months. So please keep your eyes on the literature, because we hope that this will provide you with some guidance during this sort of early period as we try and deal with these changes from an obstetrical and anesthesia standpoint. So in summary, there are new guidelines coming out from these OB and anesthesia societies. We're going to have to grapple with these for a while, but we hope that the SOAP consensus statement will help you once it's released. We will need to modify our OB anesthesia practice accordingly, so it's very important that you keep an eye on these guidelines, establish local protocols between your partners in your group, obstetricians and hematologists, and ensure that we keep good communication and maintain it early and it's ongoing between the OB and the patient during this intervening period. Thank you for your attention, and obviously I'll be taking questions at the end. Feel free to email me or tweet me.